everybody. To the next 50 minutes, we will speak about terminology and segmental analysis. And I hope I can show you a very simple approach to understand the language and the anatomy in congenital heart disease, which can be very, very complex. I don't have any conflicts of interest. So after completion of this presentation, you should be able to understand the terminology and the philosophy of the segmental analysis, and to describe the segmental approach to cardiac anatomy. So we will speak about the segmental analysis, the segmental approach, define the atrial arrangements, the cardiac positions, go over the 3 segments of the heart, and then define the connections. And if you have time, we will also speak about looping. So when you see a patient in the echo lab, and you just start with a parasternal long axis view or an apical 4-chamber view, there's the question, what is what or who is who? You cannot tell from these images. You don't know, is this a left ventricle? Is this a left or a right atrium? Or is this the right atrium? Or is this the left atrium? You don't have any clue. And what they actually do in cardiology and in all the echo labs, and probably all around the world, the pediatric labs are exceptions. We are very dangerous what we are doing. We just assume that the right ventricle or the right atrium is on the right. This is not always the case. So we have to be very careful. So when you start imaging patients, you need to have a very systematic approach, because congenital heart defects can present in various forms and combinations. The anatomy can be very complex. The morphology can be very complex. And in addition, the congenital heart surgeons make our life even more difficult. They modify the underlying anatomy and pathophysiology. So you always start with a subcostal view. You never start with a parasternal or apical view in a congenital patient. Actually, this is true for every patient who travels through an echo lab, because you cannot assume that the right atrium is on the right. And then last but not least, you have to be very innovative. You have to acquire atypical views to define the entire anatomy and all the connections of the heart. So if a congenital heart disease patient presents in a hospital or in an emergency room, everybody is confused or even terrified, because our patients, they have procedures named after physicians and surgeons. They're very difficult to spell these procedures sometimes, and everybody's confused. We don't know sometimes what's right, what's left, what's superior, what's inferior. And at times, even people are confused or working with these patients in their daily practice. So what's the philosophy of the segmental analysis? So the philosophy of the segmental analysis is founded on morphology. And the chambers are recognized according to their morphology. Each chamber has intrinsic morphologic features. We never define a chamber according to its location, because a right atrium is not always on the right. It can be on the left, the same with the ventricle. So that's the key. We recognize the chambers according to their morphology. So you define the atrial segments first and the position of the heart. You need to identify the atria, the ventricles, and the great arteries. And then you have to define the connection between the atria and the ventricles, and between the ventricles and the great arteries. So let's go to the atrial segment first. That's where we start. So now we need to introduce the term atrial arrangement or cardiac situs. So what's the definition of the cardiac situs? The cardiac situs is defined by the position of the morphologic right atrium, period, nothing else. And this is independent from the cardiac position, cardiac orientation, or position of the ventricles or the great arteries. So the cardiac situs is defined by the position of the morphologic right atrium only. So this brings me to the next term, cardiac position. The cardiac position describes the position of the heart within the chest. And actually, there are two terms, the cardiac position itself and cardiac orientation. And actually, it's not the same. Cardiac position describes the position within the heart. And the terms include lever position, meso position, or dexter position. But the cardiac position of the heart depends on many, many factors. The cardiac malformation, mediastinal or thoracic structures, tumors in the chest, or previous surgical procedures. So for instance, in my heart, if I have a right pneumonectomy, the mediastinum shifts to the right. I have a normal anatomy of the heart, but I have a dexter position of my heart. In contrast to cardiac orientation, that's a different term. Cardiac orientation includes levocardia, mesocardia, or dextrocardia. And what's the definition of cardiac orientation? Cardiac orientation describes the axis between the base and the apex on the heart. If this axis points to the left, then you have levocardia. If the axis points to the right, then you have dextrocardia. And if the axis between the base and the apex of the heart is in the midline, so if you get the perfect apical four-chamber view from the subcostal window, then you have mesocardia. So what about the atrial arrangement of the cardiac situs? So cardiac situs solitus is defined by the morphological right atrium, which is on the right of the morphological left atrium. That's the description. You have a mirror imaged arrangement of the atria or a cardiac situs inversus if the morphological right atrium is on the left of the morphological left atrium. And then you have situs ambiguous or indeterminate sidedness in the setting of isomerism, and I will come back to that. And actually we have a cardiac situs, a pulmonary situs, and an abdominal situs, and usually they are in harmony. So in this setting, in the usual arrangement of the atria in cardiac situs, pulmonary situs, and abdominal situs solitus, then the right lung is on the right, the morphological right atrium is on the right, and the liver is also on the right. If I have a mirror image arrangement of the atria, the right atrium is on the left, the right lung, the morphological right lung is on the left, and the liver is also on the left. So if you know the pulmonary situs or the abdominal situs, then you also know the cardiac situs, because they are in harmony, usually. Not always, there are exceptions. But you can start with a chest X-ray. Just have a look at the chest X-ray. Where is the stomach bubble? Where is the liver? And how is the bifurcation of the bronchi? And in this patient, the stomach bubble is on the right, on the left, on the right, and the liver is on the left. So I have a situs inversus, and the right diaphragm is lower than the left diaphragm because the heart is pushing down the right diaphragm. So we have dextrocardia. In this setting, you have cardiac situs inversus with dextrocardia. So you always start with a subcostal view to define the abdominal situs. You see the liver and you see the aorta and the IVC, which is on the right, and the aorta is on the left. The liver is on the right. Then you know this patient does have abdominal situs solitus, so this patient probably also has cardiac situs solitus. In contrast to this patient, where the liver is on the left, the IVC is on the left, but the aorta, abdominal aorta, is on the right. So you have an abdominal situs inversus. So this patient does have cardiac situs inversus. You can also have a look at the chest X-ray here. If you start with the subcostal view, it can be very difficult sometimes. Where is the aorta? Where is the IVC? Then what you do, you just take a chest X-ray, like in this patient. You see here, the stomach bubble is on the left, the liver is on the right, but the right diaphragm is a bit lower than the left diaphragm, and the apex points to the right. So in this patient, you have a usual arrangement of the atria with dextrocardia, and actually indeed, you see here the pulmonary veins are coming in, and usually the pulmonary veins are connected to the left atrium, but there are a lot of variations. So the left atrium is on the left, this is then the right atrium, which is on the right, so you have a cardiac situs solitus with dextrocardia. Or in this example, the liver is on the left, IVC is on the left, the aorta is on the right, so abdominal situs inversus. So this patient probably also has cardiac situs inversus, so it means the right atrium is on the left and the left atrium is on the right. So this is the right atrium and this is the the left atrium, and the base apex axis points to the left, to the right. You have dextrocardia. So if you get this view from the subcostal window, you have defined this as the right atrium, left atrium. You see, you get the perfect four-chamber view. The liver is on the right, so you have a cardiac situs solitus with levocardia. Or in this example, the IVC is on the left, the aorta is on the right, and the liver is also on the left. So you have an abdominal situs inversus. It means this patient also has an cardiac situs inversus or mirror image arrangement of the atria. And what you see here, you have a kind of a four-chamber view from the subcostal window. So this is mesocardia, situs inversus with mesocardia. So how do you identify now the atria and the ventricles and the great arteries? Let's go to the atria first. The atria have a specific morphology, an intrinsic morphology, and the appendages are the landmark for morphologic rightness and leftness. But now we have a problem when we do echocardiograms. By the TTE, we can usually not see the atria appendages. That's impossible. So we will need to do a T on every patient, but that's not practical. So this is the reason we take an indirect approach to define the morphology of the atria. So the right atria appendage and the left atria appendage are the morphological landmarks for rightness and leftness. The right atria appendage has a triangular shape, a very, very broad base, and a lot of pectinate muscles within the appendage extending all around to the vestibule of the tricuspid valve. That's a T on a patient with a normal anatomy of the heart. You see this triangular shape, the broad base of the right atria appendage, as we see. So this is the morphological right atrium radium. And the left atria appendage is different here. That's the left atria appendage. You have a very narrow entrance. The appendage has a hooked shape appearance, and the pectinate muscles are confined within the appendage. You don't have any appendages within the chamber of the left atrium. There's no terminal crest. Sometimes you're very, very lucky to see the left atria appendage on a surface study, like on this patient. You see this narrow entrance of this appendage here. That's the shape of a left atria appendage, as described before. Then you know this chamber here must be the left atrium. But usually that's what we do, that's T. You see this hook-shaped appearance of the left atria appendage, the narrow entrance. You know now this is the left atria appendage, and this chamber here is the left atrium. The image quality can be very poor sometimes. You cannot see the IVC or the abdominal aorta. And then the question is, what's what? which atrium here is the right one and which one is the left one. What you can also do, you can inject bubbles. And then when you inject bubbles, usually the bubbles appear then in the morphological right atrium, because the SVC is usually connected to the morphological right atrium. You know now, okay, this is the morphological right atrium. So this patient does have mirror image arrangement of the atrium, because the right atrium is on the left and the left atrium is on the right. This is in a patient with CCTGA and dextrocardia. You can also do a chest X-ray. This can also help to define the cardiac cytos. You see here the stomach bubble on the left again is the shadow of the liver. So abdominal cytos inversus. So this patient probably also has cardiac cytos inversus, and the right diaphragm is lowered because the apex pushes down the right diaphragm. Dextrocardia. So mirror image arrangement with dextrocardia. So my question to you is, what's this structure here in this apical four-chamber view? Is this a thrombus or a tumor? Or what is it? Or is it the normal structure within the heart? What I see usually, we see these structures if you look for them when you do a TTE. What's happening, the cardiologists are ordering a CT scan or an MRI or do a TE to rule out a thrombus or a clot or a tumor. But that's a normal structure, which is called terminal crest. And the terminal crest is a remnant of the right-sided sinus venosus valve. That's a structure of the morphological right atrium. So this also helps you to identify the right atrium. If you see this terminal crest, you know this is the morphological right atrium. The left atrium does not have a terminal crest. So let's now go back to rightness and leftness of the atria and our organs. Usually we have paired organs like atria or lungs, but these organs are not identical. The left atrium looks different from the right atrium. The right lung looks different from the left lung. But in the setting of isomerism, we also have these paired organs, but there's a mirror image set of normally single, non-identical organ systems, like the atria or the lungs. So in the setting of right isomerism, you have paired morphological right structures. You have two right lungs, you have two right atria. In the setting of left isomerism, you have paired morphologically left-sided structures. You have two left lungs, you have two left atria. Usually patients have multiple spleens and many different congenital heart defects are associated with isomerism. So this is a right isomerism. You see here, you have two left lungs, right lungs, one on the right and one on the left. You have two right atrium, one on the right and one on the left, and the liver is in the midline, and you have malrotation of the gut. So please do not call the left-sided right lung a left lung, because this left-sided right lung is not a left lung, it is a right lung. So in the morphology, in this setting, the setting of right isomerism, you call this the right-sided right lung and the left-sided right lung, or the right-sided left atrium and the left-sided right atrium. Do not call this left atrium, because it is not the left atrium, it is a right atrium. The same in the setting of left isomerism. You have paired organs, left-sided structures, right-sided left lung and the left-sided left lung, a right-sided left atrium and a left-sided left atrium. That's the way you call it. So this brings him back to identify sightness or the sightness of the lungs. So the right lung usually has 3 lobes, the left lung 2 lobes. This helps, but that's not the accurate method to define the pulmonary sightness. You need to look to the journey of the right and left pulmonary artery. What's the relationship between the right and pulmonary artery and the right upper lobe bronchus? So in the setting of pulmonary sinusitis, the right pulmonary artery travels anteriorly to the right upper lobe bronchus. In the mirror image arrangement of the lungs, the right pulmonary artery travels also anteriorly to the right upper lobe bronchus, but then on the left side. And the left pulmonary artery travels posteriorly to the left upper lobe bronchi. In the setting of right isomerism, we see here the right pulmonary artery on the right and the right pulmonary on the left travel anteriorly to the right upper lobe bronchus on both sides. In the setting of left isomerism, the left pulmonary artery travels posteriorly to the left upper lobe bronchi, and on the left, on the right, and on the left. So that's the proper assessment of the isomerism in the lungs. So I ask you, what's the cardiac situs in this patient? That's an apical 4-chamber view. That's probably a single atrium. There's no chamber here. There's a univentricular connection. But what are these structures here? These are the left atrial appendages with this narrow entrance, hook-shaped appearance. So these are left atria on the left side and on the right side. So this patient does have left isomerism of the atria with the right-sided left atrium and the left-sided left atrium. This brings me to another term to clarify the difference between connection and drainage. Connection and drainage are different terms. They are not interchangeable. A connection describes an anatomic link between 2 structures, between the atria and the veins, or atria and the ventricles and great arteries. Drainage is a hemodynamic term. It defines a blood flow direction. So let me go back to this patient here. This patient's isomerism has a single atrium, but the pulmonary veins connect to the left-sided left atrium. It's a normal connection of these pulmonary veins, but these pulmonary veins also drain to the right-sided left atrium. Do you see now the difference? You cannot interchange drainage and connection. We always say in patients with superior sinus venosus defects, the right upper pulmonary veins drain into the SVC. Actually, this is not correct. The correct description is the right upper pulmonary vein connects to the SVC, because you describe the anatomical connection. You don't describe the hemodynamic consequence. So you need to be very careful how you use these terms. You need to understand the difference of the terms. Connection is not the same as drainage. So that's again another patient. It's a subcostal view. You see here, there's the spine here. There's no IVC, and there's a vessel crossing here. The spine, that's the azygos vein. And there's no IVC, and the hepatic veins directly connect to the right-sided atrium. That's a patient with left isomerism. And the IVC is absent. There's no intrahepatic IVC, and that's a typical finding in patient with left isomerism. You can also have a look at the chest X-ray. You see here, you don't clearly see a stomach bubble here, and there's a shadow in the midline of the abdomen. That's the liver, which is transverse. And what you see here, a very symmetric bifurcation of the trachea. And if you see a very symmetric bifurcation of the trachea, this is very, very suspicious of isomerism. This is patient with left isomerism. So in this patient, you have a liver here, that's the spine, and here is the aorta and the IVC. And the IVC and the aorta are on the same side of the spine, here on the left side. This is a patient with right atrial isomerism, actually this setting here. So when you describe the atria, you need to look for anatomic features. And what are anatomic features of the atria? You have any questions? Okay, please mute your microphone. So the appendages are very accurate morphologic landmarks for rightness and leftness. Different morphologies described. In the right atrium, we have many pectinate muscles. We only have a few in the left atrium, confined to the left atrial appendage. In the right atrium, there's no terminal crest. The terminal crest is absent in the left atrium. So now let's move to the next step. We need to identify the ventricular segment. So here in the apical four-chamber view, the question is which ventricular chamber is the left and which one is the right one. So what we do, we look at the setting of the AV valves, and the tricuspid valve is more apically positioned than the mitral valve. And if you can identify the tricuspid valve, then you can also identify the right ventricle, because a tricuspid valve always communicates with a right ventricle, and the mitral valve always communicates with a left ventricle. So the AV valves correspond or communicate with the corresponding ventricle. That's the other setting. You see here, the left-sided AV valve is more apically positioned than the right-sided AV valve. So this is the tricuspid valve, and if you know the tricuspid valve now, you know now this is the right ventricle. Another morphologic feature for the left ventricle is the fibrous continuity between the AV valve and the semilunar valve. You see here in this setting, there's a fibrous continuity between this AV valve and the semilunar valve. You know now the underlying ventricle is a morphological left ventricle, and this is the mitral valve. You don't know yet if this is an aorta or a pulmonary artery. You don't know this, but you only know because of this fibrous continuity here. This is a mitral valve, and this is then the left ventricle. That's another example in a patient with a master procedure. You see here, this valve is more apically positioned. This is the tricuspid valve, which corresponds with the right ventricle, and the right ventricle has a moderator band and a lot of trabeculations. That's another morphologic feature. So my question to you is, that is an atypical view. You see here an AV valve and a semilunar valve. My question to you is now, is this now a right ventricle or is this a left ventricle? How can you define the morphology of the ventricle? Is it the right one or a left one? So what's this structure here? That's the ventricular crest. And the ventricular crest is a morphologic feature for the right ventricle. So the ventricular crest intervenes between the tricuspid valve here and the semilunar valve. I tell the semilunar valve. I don't know if this is an aortic valve or a pulmonic valve yet. I only know it's a semilunar valve, but I know that this is a tricuspid valve because of this ventricular crest. And this ventricular crest is also a demarcation junction between the outlet septum and the pulmonary infundibulum. So this is a patient with a situs inversus and dextrocardia and CCTGA. So what you see here, there's no fibrous continuity between this AV valve and the semilunar valve. You know now this is the morphological right ventricle. So there are characteristic features to identify the tricuspid valve and the right ventricle. Typically, that's very reliable. The tricuspid valve is more apically attached to the septum and the ventricular crest. The mitral valve does have a fibrous continuity to the semilunar valve, and if you can identify the mitral valve, then you know the underlying ventricle is the left ventricle. And the last segment is the arterial segment. So the arterial segments includes an aorta or a pulmonary artery or a common arterial trunk. So what's the definition of an aorta? An aorta gives rise to the coronary arteries and to the branches to the head, like here. The pulmonary artery has a very, very short trunk, and then this trunk bifurcates into the right and left pulmonary artery. The common arterial trunk is another arterial segment. And what's the definition of a common arterial trunk? So there's a common arterial valve, and the trunks gives blood supply to the coronary arteries, to the pulmonary arteries, and to the systemic arteries. This is the definition of a common arterial trunk. Please do not call this valve as an aortic valve. This is not an aortic valve, this is a truncal valve. Even when the patient undergoes repair of a common arterial trunk, this valve should not be called an aortic valve, it should be called a truncal valve. So that's an example or anatomic specimen. You see here, the subtruncal ventricular defect. Remember how I call it? It's a subtruncal, not the subaortic, the subtruncal ventricular defect with a truncal valve and the common arterial trunk, which then gives rise to the coronary arteries, to the aorta and the pulmonary arteries. So now we have to define these three segments, the atria, the ventricles, and the great arteries. Now we have to define the connections between the atria and the ventricles, between the ventricles and the great arteries. That's what we have to do. How do we define these connections? There are different connections. The connections can be concordant or discordant. They can be isomeric, or you can have a univentricular connection. So in this setting, in a patient with situs solitus, the right atrium here, the left atrium here, that connects with the right ventricle and the left ventricle. So we have a concordant AV connection. But in this patient with a situs solitus, the right atrium here, the left atrium here, and you see here, this is a right ventricle. So the left atrium connects to a right ventricle and the right atrium to the left ventricle. You have a discordant AV connection. If you go further here, you see here in a patient with situs solitus, this is the tricuspid valve and the right ventricle, the mitral valve and the left ventricle. And you have a discordant AV connection. If you do an anterior loop, then you can do this view. Then what you see here, this left ventricle connects to an artery here. And you see here the parallel position of the great arteries. And if you see this parallel position of the great arteries, you know this patient must have transposition of the great arteries. And please do not call these arteries vessels. Do not use the term transposition of the great vessels. That's wrong. Vessels is a general term, and vessels includes arteries, veins, and collateral vessels. But here we refer to the great arteries, so the correct description is transposition of the great arteries. This is a very short trunk, and this trunk is then the pulmonary artery, and you have a discordant VA connection. If you take the same patient here with the pulmonary artery here, LV to PA, and the right ventricle connects to an artery which has a very, very long segment, which is the aorta. So there's a discordant VA connection. So what's an isomeric connection? So in a patient with right isomerism, left isomerism, we cannot call the connection between the atria or the ventricle a concordant connection. That's wrong. You need to call this connection isometric connection between the atria and the ventricle. So the last connections we have to describe or to define are the univentricular connection. So let's start with the atria. You can have all combinations. You can have solitus, situs inversus, or isomerism. Then there are two options to connect between the atria and the ventricle. Please mute this microphone, please. You can have to connect. The right-sided AV valve can be absent, or the left-sided AV valve can be absent, or both AV valves can be present. You have a double inlet connection. And the AV connection can connect to a dominant left ventricle or a dominant right ventricle, which is very, very rare, or an indeterminate ventricle. And I don't know if now a morphological right or a morphological left ventricle. So this brings me to another term, overriding and straddling. So what's straddling? What's a straddling AV valve? So a straddling AV valve describes just an anomalous insertion of a tendinous cord of the papillary mass into the contralateral ventricle. So this means you need to have a ventricular septal defect. Overriding is a different term. Overriding describes a malalignment of the annulus of one AV valve or a semilunar valve relative to the ventricular septum. So you can also use this cartoon to describe the difference between straddling and overriding. You see here, this is the ventricular septum with the ventricular septal defect, and here are the cords. So the cords insert on both sides of the ventricular septum. They cross the interventral septum and insert on the contralateral side. That's called straddling. But in the setting of overriding, you have a malalignment between the ventricular septum and the atrial septum. And you can have a combination, overriding and straddling. So here, you have a patient with a univentricular connection, situs solitus, left atrium, right atrium, and you see here there's no connection between the right atrium and this hypoplastic right ventricle. That's tricuspid atresia or an absent right-sided connection. So how do we define a double inlet ventricle? So this is the normal connection without overriding of the septum. That you can have a concordant connection with a mild overriding between the atrial and ventricular septum. But here you have a severe overriding and malalignment then of the atrial and ventricular septum. And then we come to the 50% rule. If the overriding is more than 50% and the atria predominantly connects to a left ventricle, then we call this a double inlet left ventricle. That's an example here. You see here, cytosolitus, right atrium, left atrium. And you see a malalignment of the atrial septum and the ventricular septum. There's an overriding. And you see, these valves are on the same plane, so you cannot call these valves mitral valves and tricuspid valves. You just call them right-sided and left-sided AV valves. And what you see here, these tendinous cords of this right-sided AV valve insert on both sides of the ventricular septum, on the right side and on the left side. That's straddling. How do we define double outlet ventricle? In the setting of a double outlet ventricle, both great arteries arise from a predominantly one ventricle. Again, there's no overriding here. You just have a ventricular septal defect. You have a mild overriding or malalignment of the outlet septum relative to the remainder of the interventricular septum, for instance, in the setting of tetrarchy fallow. But if the overriding is more than 50%, again, this 50% rule, and then the right ventricle or both great arteries predominantly communicates or connects to the right ventricle, then you call this a double outlet right ventricle. So like in this setting, in a patient cytosolitus, that's the left ventricle, that's the right ventricle. And what you see here is severe overriding of the ventricular septum, and this aorta overrides more than 50% and predominantly connects to the right ventricle. So this is a double outlet right ventricle. So let's go to looping. How do we describe the looping? That's a very difficult for many of us to understand. So during the first couple of weeks, we have a primitive heart tube with the primitive atrium, sinus venosus, primitive atrium, and the primitive atrium connects to the presumptive left ventricle and not right ventricle. It connects to the presumptive left ventricle, which then connects to the presumptive right ventricle and coronary truncus. And then you have a looping between the presumptive left ventricle and presumptive right ventricle here. So I ask you now, in a normal heart, in your heart, do you have a D loop or an L loop? Just ask this question, or just ask your supervisors and ask your cardiologist if they know, does your heart have a D loop or an L loop in the normal setting, in the normal heart? How do we define looping? The easiest way to define looping is the following. You just take an apical four-chamber view. If the inflow portion of the RV lies to the right of the morphologic LV, then you have a D loop. If the inflow portion of the morphologic RV lies to the left, then you have a D loop. So like here, in this patient with a master procedure, you see here we said, okay, this is a tricuspid valve and the right ventricle, so the right ventricle lies to the right of the morphological left ventricle. So I have a ventricular D loop. The trunk position of the great arteries. But in this patient, we said this is the tricuspid valve, which is more apically positioned than this one. So this is the right ventricle, which is on the left of the left ventricle. So we have a ventricular L loop in the setting of CCTGA. So my question to you, can you define looping from a parasternal short axis view? To give you the answer, no, you can't. Never define a looping from a short axis view, because the position of the aorta and the pulmonary depends on the position of your transducer. So in the short axis, you just describe the position of the great artery in relation to the pulmonary trunk. But you can take another approach to define looping. You can take an apical view and you go very anteriorly to identify the pulmonary artery and the aorta. And then you see the parallel position of the great arteries. And then you see here, the aorta is on the right of the pulmonary artery. Then you have a ventricular D-loop or D-down position of the great arteries. The question is this a D-loop or an L-loop? You cannot tell in the apical, in the parasternal short axis view. This is a patient with a master procedure again. That's a D-loop. And you can again go to the apical view, go very anteriorly, and you see here the parallel position of the great arteries, the aortas to the right, then you have the down position of the great arteries. So this is a patient with situs inversus. You see here, the liver is on the left, the IVC is on the left, the aorta is on the right. So abdominal situs inversus, this patient must also have abdominal situs inversus. Now I know this is a patient with congenitally corrected down position of the great arteries. And as I said before, with situs inversus, it means the right atrium is on the left and the left atrium is on the right. So this is the right atrium. Now, this valve here is slightly more apically positioned than this one. So this is a right ventricle. So why does this right atrium connect to a right ventricle? Something is wrong here. If we put together the puzzle, the sonographer reversed the transducer. They do that sometimes because they know in a patient with CCTGA, the right ventricle should be on the left, like here. So that reverses transducers to have a picture which is familiar to them, but that's forbidden. That should never be done because you don't know what's left or right anymore. There are international agreements where you position the transducer or where you position the indicator of the transducer so that you can identify rightness and leftness. But if you mix up this convention and if you don't adhere to the recommendation, I cannot tell anymore what's right and left. So what happened here, the sonographer reversed the transducer actually, so that's actually it's right, not left, and that's left. So now it makes sense. This patient has deep down position of the great arteries, and that's the problem. You only have L transposition or L loop in 95% of patients with a situs solitus and CCTGA, but 5% of patients with CCTGA have a situs inversus. So everything is mirror image arranged, and in these patients you do have a D transposition of the great arteries and the D loop of the ventricles. So D or LTGA should not be used as a synonym to describe CCTGA. So that's too close. Unfortunately, I had to start again because the session ended for any reason. I don't know why. So let's go back to this our patient to open the puzzle, to close the puzzle. So what's what and who is who? So what we don't know, if you just started a parasternal long axis here and an apical, you don't know. You cannot tell which one is the left atrium, the right atrium, or the right or left ventricle. You have to start with the subcostal views. What you see here, the liver is on the left, the IVC is on the left, the aorta is on the right. So what you know, you have abdominal situs inversus. So this patient also has cardiac situs inversus, and the base apex axis points to the right. You have dextrocardia. And if you go now to these views, you know this patient has situs inversus. It means that's the right atrium, which is on the left, and the left atrium, which is on the right. And let's identify the ventricular chambers. We identify now the atrial chamber. So this valve is more apically positioned than this one. So this is the tricuspid valve, and this is the right ventricle. And in this parasternal long axis view, again, you see this fibrous continuity between this AV valve and the semilunar valve. You know now, because of this fibrous continuity, this is a mitral valve and this is the left ventricle. So what you have here, the right atrium connects to the right ventricle and the left atrium to the left ventricle. You have a concordant AV VA connection in a patient with situs inversus and dextrocardia, and an L loop, because the right atrium is on the left of the left atrium. And indeed, when you go to the short axis view, to the parasternal short axis view, you see the great arteries are not in parallel position. The pulmonary trunk travels around the aorta. And that's the chest X-ray with situs, abdominal situs inversus and dextrocardia. Okay, so to summarize, you have to take a very systematic approach. If you don't take a systematic approach, you are completely confused and lost. You don't know what you're speaking about and what to look for. You need to take the segmental analysis, identify the atrial arrangement and position of the heart, to identify the C segments, the ventricle, the great arteries, and then you define the connections. And with it, that's what to say. You describe the morphology. What you see is what you describe. And if you take this approach, you're safe. Then you cannot be wrong. Thank you for your attention. Are there any questions? No questions? You can also type your question to the chat box. Just to remind you, you can claim credits, but you need to complete the survey link. And in January, then you will get the certificate of attendance from us. And this certificate will tell you how many hours you joined these Toronto International ACHD rounds. No questions?
Dr. Oechslin, I had just a quick question.
Yeah.
Thank you for the talk. It was really good. For the left and right ventricles, do you normally is the morphology of the ventricle, like the trabeculations or anything like that, helpful, or is it more just like the type of valve, like identifying the tricuspid valve versus the mitral valve, that's the most helpful?
That's a very good question. It's a very good. It's very helpful in the pediatric population, in newborns and young children, where the right ventricle has more trabeculations than the left ventricle. And we have the moderator band. But if a patient does have a complex congenital heart defect, then this remodeling of the ventricles over the years, and even then the left ventricle can then have prominent trabeculations or deep intertrabecular recesses, and sometimes it can be very difficult to say, is this now a left ventricle or a right ventricle? But the accurate morphologic features to define a right ventricle or a left ventricle, actually there are two. Is this the position of the AV valves, the offset, and number two, the fibrous continuity, and actually number three, the ventricular crest. Naumann has a question. Okay, I've been attending the lectures but barely filling the surveys. Would be able to get any CME certificates? Yes, you will get one. And if you go back to the surveys, if you still have the links or the invitation, I think you can still complete the survey. That's not the problem at all.
Okay, thank you so much, Dr. Erwin. I will gonna, because that was my question, because I have been attending, but unfortunately may not be regular in filling the surveys. But I do have some links. I will try my best to
Yeah,
do
okay. Yeah,
like
yeah,
this.
I remember. I see your name all the time.
Thank you so much. No, I
Yeah.
really enjoy your talk. Your talk has been very refreshing for us, and it's been very enjoyable to have a talk with, especially attending your lecture. Thank you so much.
Okay, thank you very much. It also took me a long time to figure this out, and there's a lot of information to pack in a 1-hour presentation if you want to give a comprehensive overview. And but if you take a visit it, what you see is what you describe. Just adhere to morphology, then you cannot be wrong. Any other questions? Okay, if there are no questions, then I thank you very much for attending. And next Friday, there won't be any international rounds because we will have internal performance rounds. But then we will see you back in 2 years and hope you will join us in 2 weeks. I hope you will be back in 2 weeks. Have a nice day. Enjoy your morning, afternoon, or evening. Have a nice weekend.